Hi, my name is Sean Larson, and I am part of the graduating class of 2015's nursing school. I am here to present an introduction to our patient who will be referred to by his initials, BS. He is a 64-year-old white male with the chief complaint of, "I want to get my ejection fraction up to 55% so I can get on the transplant list." BS has a history of chronic heart failure, having had a heart attack in 2007, atherosclerotic cardiovascular disease, and stage 5 kidney disease, which he is currently on dialysis for. One cause of his heart failure was dyslipidemia, which contributed to atherosclerotic plaques damaging his heart vessels. He is still currently being treated for atherosclerosis. His stage 5 kidney disease is another result of poor cholesterol, which has caused his LDL to build up and in turn damage his arteries and kidneys. In 2007, BS had a pacemaker implanted and 2 stents put in as well. He currently lives with his wife and 2 dogs. Both his parents are deceased. His father died of a heart attack at the age of 49, and his mother died of a brain aneurysm at the age of 53. He is currently retired, drinks about 6 to 8 beers a week, and bikes and walks 4 hours a week. He has no known drug allergies and no other allergies.
Hi, my name is Layla. I'm a PharmD candidate, class of 2015, and I'm from the Manchester campus.
My name is Kyle Salopoulos. I am also a PharmD candidate for 2015, and I'm from the Worcester campus.
So BS's medication record, he's on omeprazole, 40 milligrams. He's taking that for GERD. He takes it twice a day, and he's been on it for 3 to 4 years. He's on sevelamer carbonate, 800 milligrams. For his chronic kidney disease, he's taking 2 tablets with a meal, and he's been on it for 3 to 4 years. He's also on carvedilol, 12.5 milligrams for his chronic heart failure. He takes 1 tablet by mouth, BID. He's been on it since 2007. He's on simvastatin, 20 milligrams for his atherosclerotic cardiovascular disease. He's on it once a day since 2007. Multivitamin, 1 milligram, and he takes that daily. He's been on it for 3 to 4 years. Cyanocoalbumin, 1,000 milligrams for his chronic kidney disease once daily for 3 to 4 years now. Magnesium, 250 milligrams. It's a dietary supplement for him. He takes it once daily. He's been on it for 3 to 4 years. He's also on aspirin, 325 milligrams for his chronic heart failure. Takes it daily since 2007. He used to be on warfarin. It is on hold now. He was on warfarin 5 milligrams for his chronic heart failure once daily since 2007. And he also gets lidocaine ointment 5% for his chronic kidney disease post hemodialysis. He would take that PRN.
Our patient's objective information is as follows. His weight is 176 pounds. His Chem7 is all within normal limits. His creatinine clearance is less than 15 milliliters per minute. His GFR is unprovided. He doesn't know what it is, but we can assume that it's a very low since he has stage 5 renal disease. His ejection fraction, which he just received at an echocardiogram on May 26th, revealed that he has LVEF of 40 to 45%. His last LVEF was measured in 2011, and it was 25%, so it's risen 15 to 20% in the last 3 years. His ENPCR is 0.8, and the normal limit is 1.1 or higher, so he needs to get more protein in his diet. His EKERD is 1.46, and the normal limit is 1.2 or higher, so his dialysis is proving effective in removing toxins from his blood. His left and right atrium, as measured by the echocardiogram, is moderate to severely dilated, and his left ventricle is also severely dilated.
When it comes to the assessment of our patient, BS, we're going to be looking at the medication-related problem prioritization list. Our highest priority issue is that we have a dose that's not optimal. Our patient is on carvedilol, 12.5 milligrams, and he should be on a higher dose. preferably 25 milligrams. Of the medium priorities, we have a drug interaction, carvedilol and omeprazole. They have a CYP interaction, which may yield excessive carvedilol in the blood, which could be problematic. Another medium priority is duration of therapy not optimal and drug selection not optimal. Our patient is on omeprazole and he's been on this for 3 to 4 years. He could be on a different and safer medication to treat his GERD. Another medium priority problem is unnecessary drug therapy, social drugs. Our patient, while having chronic kidney disease and heart failure issues, is also consuming alcohol, which could be very problematic for him. Another medium priority is drug interactions. Omeprazole and simvastatin may interact and cause increased concentrations of statins. Since our patient complained of muscle weakness and pain, this may be attributed to it. Lastly, the low priority immunizations. Our patient needs to be on a herpes zoster and influenza vaccine.
Having gone over the medication-related problems list, our goals of therapy are as follows. Alleviate our patient's GERD symptoms, improve his ejection fraction, counsel the patient on appropriate medication use and adherence, counsel patient on non-pharmacological recommendations and the avoidance of alcohol, provide updated immunizations, and improve his quality of life. So our pharmacological plan for our patient is as follows. He wanted to increase his ejection fraction up to 55%, so that he could get onto the heart transplant list. That was his chief complaint. So our first recommendation would be to increase his dose of carvedilol, which is currently 12.5 milligrams BID, up slowly in increments over 1 to 2 week periods up to 25 milligrams by mouth BID, which was his original dose, but it was decreased to 12.5 last year after a short course of therapy with a medication that he couldn't remember the name of. And after he finished that short course of therapy, it was never increased. So because his ejection fraction in 2011 was at 25% and his most current ejection fraction measured on May 26th is 40 to 45%, we want to keep him on that higher dose of carvedilol. Our next recommendation in the pharmacological plan would be in regards to his omeprazole use. Omeprazole's normal course of therapy duration is 4 to 8 weeks. However, he has been on it every day for the past 3 to 4 years. Omeprazole can be known to cause acute nephritis rarely, and can also cause calcification in heart valves, especially with the use of warfarin, which he has been taking as well for the past 7 years up until the beginning of this year in 2014. Omeprazole also has a few C-level drug-drug interactions with the drugs on his med list. The first drug-drug interaction with omeprazole would be with carvedilol. Omeprazole is a CYP inhibitor, which can cause an increase in serum concentration of carvedilol. Because in our plan we're calling for an increase in carvedilol, this could cause toxic serum levels of carvedilol and increased side effects, so we want to avoid that reaction by discontinuing omeprazole. Another drug reaction with omeprazole is simvastatin. Proton pump inhibitors may increase the serum concentration of statins. In our patient's case, the KDIGO recommended dosage of simvastatin is 40 milligrams or less. Our patient is currently on 20 milligrams. However, the PPI that he's been taking could possibly be increasing his serum level which may cause worry because our patient is suffering from muscle weakness and pain. So we want to avoid any drug interactions that may be causing side effects with simvastatin and his muscle weakness and pain. A study we found that relates well with our patient and his omeprazole use is called long-term proton pump inhibitor use is associated with vascular calcification in chronic kidney disease by Fusaro. The question that we're answering is omeprazole an appropriate treatment for GERD in patients that are on dialysis? This general study was done on 387 patients receiving long-term dialysis treatment greater than or equal to 1 year. 295 were receiving long-term proton pump inhibitor treatments, and 92 were in a control group receiving placebos. The inclusion criteria: adult patients of both sexes who had been receiving hemodialysis for more than 1 year with informed consent in writing to the use of their medication records for the study. The exclusion criteria: patients with life expectancy of less than 6 months, evidence of cancer with the exception of basalocyoma, conditions that according to investigators could interfere with the outcome of the study. The interventions in this study: patients treated with warfarin or PPIs, or not treated with warfarin but treated with PPIs, or treated with warfarin and PPIs. The outcome and endpoints that were measured in this study were the amount of calcification of the aorta and iliac arteries in relation to PPI use. And the results in this study were measured that arterial calcifications were more common in the PPI group. Those receiving just the PPIs had increased aortic and iliac artery calcification, and patients on PPIs had proportionally greater calcification of the aortic and iliac arteries. The severity of calcification increased proportionally in patients receiving long-term treatment with warfarin as well. Male sex, PPI use, and warfarin were determined to be predictors of vascular calcification when analyzed through logistic regression models. So this study overall shows that patients who are on dialysis and have been taking warfarin and PPIs for a long period of time, greater than a year, they are at an increased risk of developing calcified arteries. Our patient has been on these for a long time, so he is at a risk, so we want to discontinue omeprazole as soon as possible. And we would recommend adding famotidine 20 milligrams every day for 4 to 6 weeks to his regimen to alleviate his GERD symptoms, but we would also like to recommend that he sees a healthcare professional to assess his GERD, as well as any adverse effects that may have occurred from his PPI use for multiple years. And finally, we want to bring his immunizations up to date and give him a zoster vaccine and influenza.
When it comes to our patients for a non-pharmacological plan, we want to make sure that we're counseling our patient to ask the healthcare provider for what type of multivitamin magnesium he's been taking. We want to check if there's an interaction there. Furthermore, we want to improve the quality of his life. When it comes to monitoring parameters, we're going to be looking at the efficacy. So we want to see the ejection fraction, has it gone up like he wants, the lipid panel, the GFR, and have we alleviated the symptoms of his GERD. Furthermore, since he is on quite a few number of medications, we want to make sure that we are checking for toxicity and adverse effects that might be happening. Lastly, when it comes to patient education, we're sort of tying pharmacological and non-pharm together here. We want him to continue exercising 30 minutes a day for 5 days a week. He's been doing a great job with that. We want him to maintain a healthy diet with high carbohydrates, low protein. For him, low protein would mean 96 grams per day, low salt diet of less than 2 grams per day. He needs to monitor his fluid intake and avoid his alcohol consumption. Furthermore, when it comes to carvedilol, he should know that the side effects will subside in 1 to 2 weeks. So when we up the dose, he shouldn't stop taking it just because he doesn't feel quite right. That'll go away. We need him to discard the carvedilol 12.5 milligrams because they are being replaced by a higher dosage. For his GERD, we do want him to try non-pharmacological ways, such as avoiding his alcohol, avoiding spicy foods, not eating right before bed, eating more frequent and smaller meals. We want him to contact the pharmacy to find out, again, about his magnesium in the multivitamins and if he should discontinue the magnesium. Furthermore, we always encourage patients to take medications as suggested by healthcare professionals.
During this interprofessional collaboration, all of our group members exhibited a healthy mutual respect for one another.
We all knew our roles and responsibilities and tended to them equally.
We had great team communication via all forms of email, text, phone calls, and face-to-face interactions.
Since we knew our roles and responsibilities, we were very accountable to the roles that we played, and we fulfilled them completely.